welcome back to Our Untoxic Podcast. I'm here with a very special guest that I've been very, very excited to bring on, Dr. Poppy Daniels of Ozark, Missouri. Dr. Poppy, thank you so much for joining us.
Well, thank you for inviting me.
Oh, it's my pleasure. I was just telling Dr. Poppy that I've been wanting to ask her on for such a long time. I really admire your work, everything that you're doing, and I can't wait to tell my audience about it. But I did not anticipate you saying yes, and I'm so thrilled that you did. So I wish I would have asked sooner, but I'm so happy to have you here now.
Well, thank you. I'm looking forward to talking with you.
Likewise. First, as we get started, can you tell us what you do, how you got into the medical profession, your background, and just what led you to what you do now?
Well, I am a OBGYN doctor. I went to undergrad and medical school at Mizzou. So
Go Tigers.
Yep. I've been in Missouri. I mean, I was not born here, but I've lived here since I was 2. So I'm a Missourian.
Yep.
And then I went to Philadelphia for my OBGYN residency and met my husband there, who's also a physician. He's an ICU doctor.
Wow.
And then I dragged him back to Missouri. And we have 6 children, and we live in Ozark. So.
Well, it's a beautiful place to settle. I'm in Nixa, and I don't subscribe to the rivalry because I'm not in high school anymore. But so I think Tigers and Eagles can coexist. But I'm so happy that you found your way here. Tell me about your practice, what you do, and what led you to that.
Yeah, so my practice is a little bit different, and I sort of intentionally created it that way because my husband and I are both physicians, and I didn't want my life to just be medicine, hospital, stuff like that. So from the beginning of my career, I've chosen to work part-time. We knew we wanted a family.
Yeah.
And I didn't want them to, not see both of us.
Right. Suffer as a result of their parents' ambitions.
Right. And so we were both in agreement that we wanted a larger family. And so I just chose at that point in time to work part-time and to really limit my practice.
Yeah.
And I think part of doing that enabled me to do a lot more of things that I wanted to do because I work for myself.
Yeah.
So I didn't work for a hospital system. I had my own practice, my own office. At this point, this was on the other side of the state in Poplar Bluff, Missouri, where we lived for about 9 years.
Yeah.
And so I just kind of built more of a holistic practice. I sort of was, at the time that I came out of training, there was a very large hormone study that came out called the Women's Health Initiative. It was actually done with HRT, or hormone replacement therapy. And it was the largest hormone study that had ever been done. It was actually a randomized controlled clinical trial, which is considered to be the sort of top level research evidence. And it was stopped early for problems. Heart attacks, strokes, blood clots, breast cancer.
Oh my gosh.
And so it was a big deal, very big deal. And nobody really knew what to do because that's sort of what everybody did. And
Right. And I assume it's not common at all for trials to be stopped halfway through due to complications because of the nature of a trial is to find out what happens.
Exactly.
Wow.
Yeah. And so I sort of decided at the time, I don't want to give a woman another problem down the road from what I'm giving her, But at the same time, I had a lot of patients that are like, look, I need some hormones, but I don't want that. So what do you got for me?
Right.
Anything else?
Yeah. And at the time, did you?
At that time, no. But I was sort of like, I'm going to look into this and really decide, is there anything else I can help these women with? So I just started doing a lot of reading, research, going to seminars, trying to educate myself on other options. And that's really when I found out about hormone testing. Ironically, hormone testing isn't done very frequently in our field. You would think that OBGYN would be doing hormone testing. But we were always taught that hormone testing isn't accurate, so you don't really do it. And then I found out that's not actually true. And there's some newer modalities of hormone testing that are more accurate. So I just started trying these things with patients because most of them were like game. They were like, because I was honest with them. I'm like, I don't really know, but I'm willing to find out.
Which is, it sounds on the surface like that would be unnerving, but for the most part, from the minimal work that I've done with doctors through my marketing business, doctors are human too. You don't know everything. You don't have a guidebook to everything. Most of what you're doing is an educated guess, or it's based off of somebody else's educated guess. So I think it's much more reassuring to work with a physician who can say, I don't know, but I will find out, versus let's try the same approach that may or may not have worked for everyone else. So
I
I
mean,
find comfort in that.
yeah, I think it would be better if doctors were more honest with their
Mm-hmm.
patients if they
Yeah.
didn't really know.
Mm-hmm.
So, I just told them, and I just have more of a smaller practice. I didn't have a lot of pressure to be like seeing, tons and
Right.
tons of patients. So I could have the time to work with my patients. And so that process led me to bioidentical hormones.
Mm-hmm.
And bioidentical just means the same as what would be in your body naturally,
Mm-hmm.
nothing synthetic. That study that I mentioned was done with synthetic HRT, so synthetic hormones.
Mm-hmm.
And there was starting to be a lot of national discussion about, is this a good thing? Is this a bad thing?
Right.
What are we doing here?
Mm-hmm.
And I would say it's probably the beginning of my awakening to how enmeshed the medical system is with the pharmaceutical industry.
Mm-hmm.
And that
Yeah.
is a problem because looking back now at my residency,
Mm-hmm.
we were poor students. We
Mm-hmm.
were working, back then they didn't limit your hours, so we were working like
Oh my
100
gosh.
hours a week,
Mm-hmm.
literally.
Oh my gosh.
So we would always joke we made less than people who worked at McDonald's because we
Yeah.
were at the hospital all the
Oh my
time.
gosh. Yeah.
But these drug reps would come in and they would take us to dinner at really nice
Mm-hmm.
restaurants.
Which is illegal now, isn't it?
I don't know
I
if
mean,
they can do that anymore. I mean, I
At
think
least not on paper.
I think that there have been more regulations since that time, but
Mm-hmm.
they would give us these really, really expensive textbooks that I mean,
Oh my
like
gosh.
$400 textbooks.
Mm-hmm.
We can't afford that,
Yeah.
So we were all just like, wow, this is great,
Mm-hmm.
not realizing they're like grooming us,
Yeah.
they're
Yeah.
grooming us to write for their meds.
Mm-hmm. And that whole thing has completely blown my mind in general, just as an adult, opening my eyes to the fact that even the medical industry, it's not what is the best fit for the patient. It's all a corporation. And I understand that business has to be done, but at the same time, it just seems so dystopian to have people saying, you write more of these prescriptions for this medication, I will reward you with golf, or I'll reward you with a trip to the beach. It just seems so.
I know. It seems crazy
Yeah.
now. And I think part of it is that whole process of realizing, the system is sort of a very dependent system.
Mm-hmm.
So, the hospital system is very drugs and surgery oriented.
Mm-hmm.
They're not health oriented. They're not fix the problem oriented. They're sort of, and a lot of people need acute care. So,
Yeah.
my husband's an ICU doctor. I understand that.
Absolutely.
He saves lives every day.
Mm-hmm.
He uses lots of drugs to do that.
Absolutely.
I'm not against that. I'm not against medications.
Mm-hmm.
But it just became increasingly clear, especially in women's health,
Mm-hmm. Yeah.
that we don't have a whole lot to offer women.
Mm-hmm.
And so that process of sort of investigating hormones and learning about hormones, I learned a lot about compounding of hormones, which is kind of pharmacies that make hormones for you in a customized way.
Yeah.
And that was mostly at that time more like menopausal women, I would say. But I sort of kind of just applied it to women of every age. So I would have moms come in and they'd say, my daughter's having terrible periods, but I don't want to put her on birth control.
Yeah.
And I know that if I go to XYZ doctor over here, that's all they're going to do or want to do. And I don't want to do that. And so I was able to work with young girls, and I really, it's so awesome to have a mom that says, I don't want that for my daughter. It's not because I'm worried she's going to
go
have sex or
yeah.
something. It's like, I don't want her to do that, and you're getting like 12, 13, 14-year-old girls
Absolutely.
being told to get on the pill. And it's really amazing to think they could be on that for
over a decade,
10 or 15 years. And we know that that is a risk factor for breast cancer.
Absolutely.
So,
which is never disclosed to you. And I think that anyone who's been on TikTok has probably seen that joke where you take the birth control, you have the sleeve and you pull out the warnings and it unfolds and it's about 7 feet tall. So I'm sure plenty of my listeners have seen that where it's 0.7 font, it's so small, but the disclaimers are endless. And to have all of that for something that they're prescribing to people who haven't even finished puberty yet. I mean, I got my first period whenever I was 9, and I know that was a little bit young, but I had, some issues with acne and with periods. And had my mom taken me to the doctor at that point, I could have hypothetically been put on birth control at the age of 9, and to not need to go off of it until I was trying to have children at the age of 23. That's a long period of time to be on something that is questionable for your health.
That's right.
Mm-hmm.
That's right. And whenever you're looking at this, a lot of women get told, we need to start the birth control to regulate your period.
Mm-hmm.
And the truth of the matter is, birth control doesn't do that.
Mm-hmm.
Birth control doesn't regulate your period. Birth control turns off your hormones. So if your hormones are going like this and your periods are crazy, heavy, irregular, or just, you're having PMS or you're having acne, if you turn all that off and you substitute this small, tiny dose of this drug, then things can get better, but you're not actually fixing anything. Right. You're just kind of doing a temporary override situation.
Right.
And so I honestly think that there are many doctors who do not get this, and nurse practitioners and so forth, because they've been told this for so long.
Right.
And then they will have someone who has horrendous periods, gets on the pill, then they have like short light periods and their acne goes away and they're happy.
Seems like a miracle drug.
Yeah. And they're like, see, we fixed you. Did you? Or did you just make the problem go away temporarily?
And the root cause will resurface when they inevitably have to go off of it later down the road.
If you never address the underlying issue, it's still there, right?
Right.
Now, granted, younger girls can have pretty bad periods at the beginning. So like the first 2 or 3 years after your period starts can be pretty bad because your body's like gearing up, right? Yeah. You're kind of figuring out how to do this, figuring out how to ovulate, how to have a period. And it can be more painful, heavier, more irregular. I'm sure that you remember days with the heating pad and not feeling good at all. Right. And some girls are missing school and throwing up and having headaches. And yes, it can be horrendous. So I definitely don't fault people for trying to seek help for that. I would want to help them with that.
Right.
And so if the only thing you're offered is, hey, this will help you, then a lot of women are like, okay, well,
I'll take what I can get at this point, especially when
it's
it's debilitating like that. But it's nice to know there's other options. When you're faced with someone like that, when a mom brings in her young daughter, then what does your typical course of treatment look like as far as trying to find the problem?
So we always do blood work and we always look at the pattern. When did your period start? What's going on? We take a really good family history. Does this run in your family? Yeah. Do women in your family have female problems or hysterectomies or infertility? That's really important. Irregular bleeding, there's generally 3 areas that we look at. One could be a structural problem. Do you have some problem in your uterus? Do you have a polyp? Do you have fibroids? Do you have ovarian cysts? Do you have endometriosis? Endometriosis is a common condition that negatively affects women's hormones, and most women on average see 8 to 10 doctors before they're properly diagnosed, which is, again, a problem of the delaying of figuring out the underlying issue.
It's an expensive and time costly treatment as well. I mean, that's the
Take
experience
this pill. See you later. That's faster.
Well, that's the sad thing too, is that you have to have time for almost every diagnosis from what it sounds like for women's health, because you have to wait to see how it affects your cycles. Your cycles only come once a month if they're regular. So if you're told we have to wait to see you after several cycles to see how it affects you, that could be 6 months. It could be 3 months, if it's timely, but that's not always the case. And you would imagine that if they're seeking out care for their cycles, they aren't regular. So it could be months before you're even able to pivot your treatment and adjust it as necessary, which is so scary whenever you're facing these issues that are so crippling.
Right.
And
as a parent of that girl, obviously you're concerned about your daughter. And so the second area that can cause abnormal heavy periods are hormone imbalances. But again, if you look back and say, oh, we don't do that, we don't do hormone testing. And I've heard it all. I've heard you're too young, you're too old, we don't know how to do that, your insurance won't cover it. I mean, all kinds of reasons to not look at your hormones. And then the third is medical issues that can cause heavy periods. So the most common being thyroid conditions.
Mm-hmm.
So I remember a girl one time came in, and her mom called me from the hospital where her daughter was getting a blood transfusion because she was bleeding so
Oh
much.
my gosh.
And she said, they want to put her on the pill now. And I just don't want to do that. I want to find out what's wrong. They can't tell me what's wrong. And so, can we come in and see? She was like panicked.
Mm.
I remember that so clearly. And we got her in like the next day, and we're
Mm-hmm.
like, and it turns out it was her thyroid.
Oh my gosh.
They hadn't even checked her thyroid.
Mm.
They didn't even run thyroid panel on
Yeah.
her. And so once we got her thyroid regulated, her periods were much,
Right.
much better.
Mm-hmm.
So again, getting to the root cause is very important.
Absolutely.
But when you have a volume driven system like most hospital systems
Right.
are, you don't have a lot of time to spend
Mm-hmm.
with patients.
Yeah.
It's not necessarily your fault. You might want to help them.
Yeah.
But
But you're
you
forced to
just,
treat the
yeah,
symptoms and
you
not the
don't have
actual
time.
condition.
And so you just kind of have to do this real quick assessment. What can we do to kind of immediately help the patient?
Yeah.
So I recognize that most doctors are trying to fix the problem right
Mm-hmm.
then.
Right.
But I think it's important for women to know if they want more than
Mm-hmm.
that, they
Yeah.
can get that. They can find
Absolutely.
someone that will dig in, do some
Mm-hmm.
investigation, and try to help them figure out what the problem is.
Which is such a breath of fresh air. And I think that what you said is so true. I mean, doctors themselves are not to be villainized. It's the system that's so broken that's forcing them to see such a high volume of patients and not to have the time or the resources necessarily to really pursue the root cause for each patient. So we're treating symptoms, we're treating pain, and then we're sending people back out the door, maybe to never find a solution because they don't know that one's available. So to have someone like yourself who's actively pursuing that and seeking out new research and not just kind of reading the textbook as some people unfortunately might only be doing, then you're able to find solutions for women who have previously been told that there's just nothing to be done.
Right.
Can you tell me the main categories of women that you see? Are you seeing people with infertility? Are you seeing postmenopausal women? What's the breakdown of your type of patients?
Well, now, I mean, previously it was pretty much all of that, the whole
Mm-hmm.
spectrum of, starting your period all the way through menopause,
Mm-hmm.
postmenopause. I have several nurse practitioners now.
Mm-hmm.
And so now I'm more focused on kind of my first love, which is fertility
Yeah.
and miscarriage
Mm-hmm.
treatment.
Yeah.
So that's really, I love that. I really enjoy that. And I really, having suffered miscarriages myself, I really want to help women with that. So that's kind of my focus right now.
Mm-hmm.
But we offer, I still see these other patients too.
Absolutely.
They're sprinkled in there.
Yeah.
But my nurse practitioners are also
Right.
seeing them, and they do the hormone testing as
Mm-hmm.
well.
Right.
They do blood work. I mean, we have 2 full-time phlebotomists in our office, so
Mm-hmm.
patients can get blood work the same day.
That's
We
very
do lots
nice.
of different types of testing as
Mm-hmm.
well. We do gut testing.
Mm-hmm.
We do food allergies.
Wow.
We do we test lots of vitamin levels. Everyone pretty much gets a vitamin panel.
Yeah.
And so it's a lot more in depth, a lot
Mm-hmm.
broader based sort of evaluation than what you would get in a traditional medical setting.
Mm-hmm.
And so I'm really blessed to have some great nurse practitioners that are working alongside me and doing a lot
Right.
of this work as well, because, there's plenty of women who need help.
Oh, absolutely. I mean, myself included. And speaking to so many women that have been so kind as to open up to me with their stories, not only do they feel underheard, undertreated, they feel alone and so many devastating side effects emotionally, in addition to how difficult this can be to just cope with physically and in so many other ways. But they were told by doctors, it's not considered recurrent miscarriages until you've had 3 or more, and then we won't look into the root cause. And that alone, I think, is so heartbreaking because for me, 1 was devastating, and then to have 2 is just a feeling that I wouldn't wish on anyone. And I think the implications of 2 back to back, maybe it's common, maybe it's not, but to still be told like you have to suffer this loss again before we'll take it seriously. And
Very cruel.
it's very cruel. And I think that sometimes I can't imagine, working in a medical setting. I'm not cut out for it for a reason. But I think that doctors sometimes can become callous to that and treat things so clinically that they forget that there's a human across the table from them. So especially when you're talking about, bringing children into the world, and it's a very emotional, very personal thing. And there's so much hope and love that's put into everything from, trying to start a family to bringing your actual child home with you, that to have it relegated down to, well, you need to have one more miscarriage before we can take it seriously. That's just so heartbreaking to me. So the fact that you take everything seriously and you're able to look at things before it gets to that stage, and you're not willing to let a woman's trauma compound before you're going to take her back for testing, I think is revolutionary.
I think that you're right when you say the doctor needs to think about that person that's across from them that's going through this.
I mean, even whenever I first told you my story, the first question that you asked me was, are you okay? You didn't ask me any further details about the medical side of it. You asked me if I was okay. And I think that that's so telling as far as your approach to being a physician. That's not been my experience in the past. And I haven't had the time to seek out other doctors. And, the first thing that I was told after being, referred, I think you should see a fertility specialist, I wanted to see you. But that has not been the experience by and large from all of the women that I've spoken to. So I appreciate you.
Well, having been through it myself, I know what that feels like. I know how much it sucks. I know how heartbreaking it is. Yeah. And it's just something where you just want someone to care and help, give you some guidance, give you some direction. And, a lot of people are turning to social media now, TikTok, Instagram. And some of the information is good. Not all of it's good.
Right.
Some of the people are, oh, if you do this, you're definitely going to have this result. And
I've everything from Mucinex to, you should be taking this vitamin to you should have this food. It's all over the place.
It's overwhelming for patients, and it can be very anxiety producing as well.
Absolutely.
So you're like, I don't know who to believe. I don't know what's right. And so I always sort of encourage people to get objective data, like have testing done, look into it, actually talk to somebody who's familiar with, the female body.
And your hormones specifically,
Your hormones. What should my hormones be doing?
Right.
What are they not doing?
And what's different with me? What's because I, even with friends that I've compared stories to, then, I took progesterone for a while and it didn't work for me. And I have had other friends that took progesterone and had healthy pregnancies right away. But for me, I just stopped having periods. So it's like your body responds completely differently to these different things. And until a doctor's able to look at everything and look at your specific data, not just case studies, then I think that it's not realistic to expect them to be able to give you accurate data because they don't have a full picture.
That's right. They don't have your personal story, your personal information, your blood work. So they're guessing.
Yeah.
And so you got to be careful. Not that I'm not telling people to stay off of social media. I'm just saying that if you're getting to that point where you're like, I don't know what's going on. I don't know if this is right. I don't know if I should take this or not take this. It's really important to speak to somebody. And I think one of the problems with miscarriage is because it's so common, then some people think it's normal. Yeah. And I always say, just because something's common doesn't mean it's normal. Yeah. And when you have been trained a certain way, it's almost like they're just telling you what they've been told instead of listening, instead of saying, really, well, tell me what happened. Tell me about your periods leading up to that. Have you been on birth control? What other issues do you have? Let's try to talk about it. Instead, it's that kind of hard line. Nope, we're not doing anything. We're not looking at it. We're not investigating until you suffer through this again.
Right. Well, that was, and I have wonderful doctors. I think it's just, like you said, it's so common that I think it's just not really looked into until it gets to a point that it demands attention and it can't be ignored anymore. So what I was told after my first miscarriage was that 1 in 4 first pregnancies do end in miscarriage. So it's 25% of the time. It's not something to be concerned about. And at the time I took a lot of peace in that because I'm like, okay, it's not just me. Something's not wrong with my body. This happens to 1 in 4 women. It's still devastating. It's still tragic, but it's not uncommon and I shouldn't panic. I will be just fine in the future. And I know that lots of women have gone on from having a prior miscarriage to having many healthy pregnancies, but I found that my peace was shattered after I had a second one because I felt like I had been lied to. And I wasn't, because the statistic is, from what I know, accurate. And I thought that I had been given this false sense of security because you told me this was normal and there was no reason to be concerned, and here I am again. So I think to be kind of given that, 1 in 4, it's so common. It's just a rite of passage, essentially. And have it never investigated just opens the door for these recurrences. And there wasn't any follow-up. It was blood work to make sure your HCG goes back down, and then it's, right back to trying and just let us know how it goes. So
the way that I look at it, so I like crime shows. I'm kind of into that. I especially like cold cases and stuff.
Yeah.
So I kind of look at myself as a medical detective.
Yeah.
And what I'm saying is that miscarriage is not normal. There is a reason why it happened. Now, we don't always identify the reason.
Right.
So I'm not claiming that you can always tell every time what happened. Many times you're told it was probably a chromosomal abnormality because that's how we were taught.
Yeah.
That the majority of miscarriages are chromosomal abnormalities, which I actually disagree with.
Wow.
Most of those statements are based on studies from the 50s. And I could be honest and say, given the fact that I have been doing this for over 2 decades, that hormone reasons are more common than chromosomal reasons. And think about it. Your period, your fertility, your ovulation, your pregnancy, all of that is a hormonal situation.
Yeah.
Okay. And so if there's even a slight imbalance in that hormone situation, that can be very devastating to the process.
Right.
But we have a lot of other things that can play into that. Like I said, thyroid issues, we have infections that can play into that. We can have sperm problems. We used to think that if an egg was fertilized, then the sperm must be good.
Yeah.
Like the egg got there, the egg fertilized.
At least
it's
you got
not
pregnant.
him.
That's not the problem. Yeah.
Right. It's not him.
Right.
But we actually don't think that now because we're seeing a devastating amount of problems on the male side. So I actually work up the males and I kind of explain that to them and I say, hey, we have to look at your hormones. We have to look at your sperm quality. We have to make sure that everything is normal on your side of the equation. Takes 2 to tango to make a baby.
Absolutely.
So
I think that's so important on so many levels. And on the very base level, it's important from the emotional side because I know that I'm fortunate enough to have a great support system. The people around me have been incredibly kind and genuine through my journey. And I know that a lot of women aren't fortunate enough to have that. But the stigma, it just makes you feel this shame as a woman. And that's one thing that I found in common with everyone I've spoken to is that you feel this sense of loneliness and guilt, like there's something wrong with me. I'm the reason that my family's not growing. I'm the reason that my husband's not a dad. I'm the reason that this pregnancy was lost. So we tell ourselves these things as women because it happens inside your body and it feels like your fault. So the blame per se is almost heaped onto you. And whenever you go to the doctor and you're the only person getting blood drawn, you're the only person getting, ultrasounds and pelvic scans and everything else, then it just reinforces that belief that it is my fault. It's something wrong with my body. It's happening in me. And even if the root cause is something to do with the female's hormones, I think that even having both sides looked at helps to shoulder the blame onto both people. And I say blame, shoulder the cause onto both people. Right. And the fact that you look at both sides, because like you said, it takes 2 to tango, it would give me more peace of mind to know that it's even possible that it's not something that's happening within me alone.
Let me tell you something. This is how bad it is out there. When I see a normal testosterone level in a guy, I'm surprised.
Really?
Because I see abnormal all day long.
Oh my goodness.
And sperm problems, motility problems, viability problems with the sperm.
And you would imagine it's environmental?
A lot of environmental aspects to it, for sure. We are sort of dealing with a major epidemic of endocrine disruptors in our environment. Which I know that it's a close topic for you to discuss.
Could you define that for people who might not know what that means?
Yeah, so an endocrine disruptor is a ingredient, a chemical, or a product that can negatively affect your hormones. And that's men or women.
And that can be found
in everything.
Amazing.
Food, plastics, a lot of the just everyday things that we use on our body, shampoo, lotion, makeup, body wash, all of these things.
Yeah.
And so I talk to my patients about the Yucca app. I don't know if you use that. The Yucca app
from
is
your
great.
recommendation.
It's really helpful for the patients to really open their eyes to, and I mean, I consider myself somebody that buys like higher quality products because
Right,
I'm aware
right.
of this issue,
Mm-hmm.
you know.
Of
But
course.
I still had to throw away a lot of stuff
Oh
in
my
my
gosh.
house.
Mm-hmm.
And you know, my husband will buy something on sale and my kids
Right.
will buy something that smells good. And I'm
Yeah.
just like, that's going to lower your testosterone.
Yeah, absolutely.
So yeah, I mean, it's a big, big problem. We have,
And sadly, it's a problem. I'm sorry to interrupt you, but it's a
mhm,
problem that really is separated by the class system. So if people can't afford to go buy clean products or products that have been cleared as less harmful to your body, then they're unfortunately stuck with the side effects of these endocrine disruptors and these products that are so harmful to them that they may or may not be aware of. And then
it's a
not
big
only
problem. And I'm
exactly.
sure you've seen how they allow things in this country that they don't allow in
Yep.
other countries.
Yep.
And it can be the same food product and it
Mhm.
can have, you know, simple ingredients over
Mhm.
here and 25,
Yep.
you know, ingredients over
Even
here.
just Coca-Cola in America versus in Europe, all the different ingredients that we have. And I think I saw peanut butter in America has all of these different ingredients that I can't spell, I can't pronounce. And then peanut butter in other countries, it's peanuts and salt.
Yeah.
So
Yeah.
it's very telling.
Have to read labels. And again, that can be overwhelming for people. So I kind of, what I tell them as I say, look, start where you are, do what you can.
Right.
When something runs out, the next time you buy something, try for a different thing.
Right.
The nice thing about Yucca is it gives you suggestions for alternative products, and you cannot buy your way into this app.
Yeah.
It's actually an algorithm driven by ingredients.
Wow.
So you cannot like say, "Oh, my product is best."
Right. Right. Which is
So
refreshing.
yeah, it's really nice to have
Yeah.
that kind of integrity there.
Mm-hmm.
So, yeah, I think it can get overwhelming because you're basically like, oh my gosh, I need to move to the middle of nowhere
Mm-hmm.
and grow all my food,
Yeah,
have my
exactly.
own cows,
Mm-hmm.
cook all my own food,
Right.
not use any plastic
Which
ever.
is so daunting for someone that, survived off of microwavable meals all through college. So I'm not cut out for that kind of life.
I mean, it's a real issue for
Mm-hmm.
people. And
Absolutely.
I'm, you know, of course we have a lot of people that are farmers and homesteaders around Missouri here,
Right.
which is great. But we can't all do that,
Right.
right? And so I think that the best advice that I have for people is to do the best that you can with your resources that you
Yes.
have. You obviously can't always go into your house and just load everything into garbage bags.
Right.
Your
And so, yeah.
spouse might be a little upset
Right.
with you
Right.
for that.
Yeah.
But, you know, just kind of think about, okay, let me just see. Let me
Mm-hmm.
just see what I'm using that might be a problem.
Right.
Let me
Exactly.
start small, you know, and
Mm-hmm.
do something like that.
Mm-hmm. Exactly.
I recognize not everybody have the resources
Right.
to, you know, do everything they want to
Mm-hmm.
do.
But everyone can do something.
Yeah.
Everyone might not be able to do everything, but everyone can make small substitutions
Right.
and at least be aware and go into things, kind of heads up and weigh your options whenever you pursue different products and different ingredients,
Right.
things like that.
I think that's the other problem with social media, right?
Mm-hmm.
Social media is like, well, if you're using this is terrible and you're going to die.
You know? Yep, exactly, exactly. Which is funny because that's the equivalent of, I feel like, the health education for women in this country as well, where you sit in health class and it's exactly like that scene from Mean Girls where they say, don't have sex, you will get pregnant and you will die. And it's essentially what we're being told. And that was something that we all laughed at when the movie came out. But I mean, if I look back at what we were taught in health class, it's very much, you cannot have sex because you will get pregnant. And there's no mention of your cycles. There's no mention of the phases. There's no mention of, there's different times of the month. There's small windows. There's not even a 100% chance that you'll get pregnant and maintain the pregnancy. And now to get to this stage and to see this is a very, very intricate process that not only do you have a small several day window every month that you can get pregnant, but your partner might not be compatible with you as far as, blood of the fetus and like you said, sperm quality. And you never know if you will actually have the embryo implant. And there's just a million things that are so far over my head, but we were never taught that at a young age. So you grow up with this unhealthy fear of being intimate with a partner because it will result in a child every time is the assumption. And then, you get older, and I went off birth control whenever I first got married just because I had this fear in the back of my head because I had been on it for so long. Again, I went on it whenever I was so young because of acne and periods and everything else. So having been on it since I was 16, at 23, I was like, I should just go off of this because, if we got pregnant, it would be good. We're just not trying yet. And, we took other precautions for a while. And then when we started trying, I was like, this should be so easy because we're trying. So it should be just like that. Mm-hmm. And to find out now that I hadn't even heard luteal phase and everything else until I started researching it post miscarriage. So can you talk about the gaps that are in education for women and how there are so many things that have to go right for pregnancy to occur, things like that.
Yes, absolutely. I mean, I always say we can teach you how to put a condom on a banana, but we can't teach you about the menstrual cycle.
Apparently not. That's
about the fertile window.
Yeah, that's where we draw the line.
About the fact that you can only get pregnant about 6 or 7 days out of the cycle. And so if women and men, because men need to know this stuff too.
Right.
If they were taught about hormones and fertility and the reproductive cycle and really like encouraged to learn these things
versus just heaping it on the woman to figure out.
Yeah. We've got a whole society of, well, you don't want to be pregnant. And so, and then what happens to a lot of women is then they end up on birth control for 10, 12, 15 years. Yeah. Then they come off to try to get pregnant. Then they can't get pregnant.
Yep.
Or they're miscarrying. Then they're told to do IVF, which is very, very expensive and for some people not morally acceptable.
Right.
And then
not to mention just the toll it takes on a woman's body. I mean, at the very, very base level, even if morality and cost aren't a factor, it's not easy for a woman to go through. So it shouldn't be the first line of defense.
No, it's really blasting you with hormones.
Yeah.
And then once maybe you have 1 or 2 kids and then you're in your 40s or 50s and they're like, oh, well, you need to have your uterus out now. Yep. It's like, wow, the stages of a woman's life are really controlled in this manner in a lot of ways. And that is because we don't have a lot of respect for the underlying mechanism. Most doctors actually aren't taught about, like in our office, our patients do charting. And that's kind of, a lot of people are like, charting is like kind of old fashioned, It's like, no, this is actually how we tell what's going on with your cycle and your hormones. But most doctors aren't trained in that. And so the idea that we could actually dissect your hormonal situation and figure that out is really, I'm sad to say it's unusual to have a doctor be able to address that.
Yeah.
And even so, when I was in training, we had IVF. But it was not like the first line thing that you were offered. It was kind of a last resort.
Right.
Okay. And so we were trained in a ton of fertility stuff. Well, now, and this is funny because I actually just had this conversation with the fertility surgeon that I work with in St. Louis. He's kind of like me, except he does the surgery side. And he told me, he said, these doctors coming out, these fertility doctors, they're not doing surgery. He had called me because he had done a 9-hour surgery on one of my patients for stage 4 endometriosis. And she had it on her colon and needed some portion of her colon removed. I mean, she's young. Do
you mind to give us a brief overview of what endometriosis is?
Yeah, so it's a condition that we don't totally understand. I personally think it's an autoimmune disease.
Wow.
I really do. And what happens is it creates this inflammatory process on the inside of your body. And that inflammation causes a lot of pain.
Right.
So painful periods, heavy periods, painful intercourse, sometimes pain going to the bathroom, a lot of conditions like that. But it is hard to diagnose sometimes. So you can have an ultrasound that looks totally normal and still have endometriosis. Wow. Another patient he did surgery on of mine. So this patient, her and her husband have been trying for quite a while. She did not have painful periods. She did not have painful intercourse, but she had this persistent cyst. And I told her, I said, I think you're really going to have that removed. Right. It's not going away. So I sent her to him. She ended up having stage 4 endometriosis. Wow. And he was shocked. I was shocked because her presentation was not typical. And I'm not saying everybody has to jump right into surgery at all.
Right.
I'm just saying that there can be some real serious conditions that are affecting your internal organs.
Of course.
If you do have those types of symptoms and you've just been told that's normal.
Right.
Because a lot of women are told that. They're told, oh, it's normal to have terrible periods where you can't get off the couch and you have to miss work or school.
And I think it's so sad that it's often, it's relegated down to you can't tolerate periods. You're not tough. You need to take some Tylenol, get your heating pad. Other women don't have it that badly. And I think that there's such a disconnect between women where some people are on the opposite side, I've been fortunate to have fairly easy periods since I've been off of birth control once I leveled out. So for me to look at someone else who has those struggles and to say, it's not that bad, you just need to get over it. I can't imagine doing that because there's so many other factors that would contribute to her experience. So I think as a group, women and men, we all need to understand that there, like you said, are so many factors that will influence what your cycles are like, what your hormones are like. So it's not fair for me to say periods are not that bad. Why can't you go to work? Why are you on the couch? Why are you complaining that much? It's not the truth. And I mean, you could say the same thing for pregnancy too. One woman might say it's not that bad. You can still do all of these things. And one woman might say, I almost died being pregnant. So there's a completely massive spectrum of ailments that you can encounter with both of these things. So I again, admire what you're saying with understanding.
You have to listen to the patient. Like, I think that's really what's missing a lot of times. Like, listen to what they're telling you. The patient will tell you what's wrong with them if you will ask the right questions and let her speak. So and it's an issue, but sometimes we do get cases that are atypical. But one of the things that I say in our workups, like for fertility or miscarriages or whatever, I say, if you haven't had a complete evaluation, you really can't say what's going on.
Right.
And for a doctor or a nurse practitioner, or whoever, to tell you, just keep trying, to me, that is a very poor reflection on them. What they're saying is, I don't know what's wrong. I'm not going to look into it. I want you to keep going through this. I don't have the time for you. Well, then you shouldn't have the time for them. Because remember, your money pays that doctor or nurse practitioner, whoever. Whether it's your insurance money or your cash money, you're hiring them to care for you. If they're not caring for you, if they're not investigating, or if they're just not compassionate, not answering your questions, talk with your feet.
Absolutely.
You don't have to stay. This is not prison.
Yeah.
You are not like,
absolutely.
You're not required to see this. You know,
absolutely.
So I think sometimes patients have this like Stockholm syndrome.
Like you're made to feel like you can't leave.
Yeah. Like, oh my gosh, if I don't see this person, then I'm not going to have a doctor or whatever. I'm like,
or you think you're being over dramatic by considering seeking, if you're told this is normal, you shouldn't worry about this. You should just keep trying. And then you think, I want a different answer. I want to see someone else, a specialist, get a second opinion. Then you're almost warring with yourself thinking, am I being too dramatic because they told me it was okay? Yeah. I don't feel like it's okay, but I am not the medical professional. So if I'm seeking a second opinion, am I just, wasting money going to someone else? Because just the casual nature.
That's the other thing that we get. We get a lot of people saying, oh, that's expensive. And that's, and I'm not saying it's for everybody. But here's the truth. Insurance does not pay you to spend time with your patients. Yeah. Insurance pays you to see the most patients you can see in the shortest period of time. That's where your reimbursement is. Yeah. So if you're like, our initial appointments with you are an hour, our follow-ups are 30 minutes. And that's because you can't fix these things in 5-10 minutes. Yeah. And so if that's why people sometimes have to save to come see this. And I highly respect that. I understand not everybody has that capacity, but the reason that we have prioritized, like I stopped taking insurance in 2010 because I wanted to spend the time with the patients, and the insurance reimbursement just was not adequate. Right. And at the time, so this is 14 years ago, that was kind of unheard of.
Yeah. I was going to say, it seems like a newer wave of practices going independent. So you were very ahead of the curve.
Yeah, it was not common. And in fact, when that happened, I lost a lot of patients. And a lot of them were very nice. They're like, look, I like you, but I have to go where my insurance says. Right. I'm like, fine, I'm not mad at you. I understand. Yeah. I get it. But, a lot of them came back. Yep. Because whoever their insurance was paying for was, again, not always looking into the problem. Of course. And so they're like, well, I would rather pay out of pocket and come see you because I know you're going to do tests. I know you're going to listen. I know you're going to try to fix the problem. Right. And I really want it fixed. And I don't want to just waste the Band-Aid.
Yeah. Well, that's the incredible thing is I think that it's spun. There's this narrative that if doctors go independent and they don't take insurance, it's because you're a boutique service and you want money. But on the contrary, from your explanation, it's the opposite. It's that I want to be able to spend an hour with each patient and maybe take 6 patients a day instead of taking 20 patients a day and getting that insurance reimbursement, but seeing each person for 12 and a half minutes and then going to the next person and keeping everybody waiting in a room and having this whole, rotating practice of women who are not feeling heard. So I really resent that that's the narrative that's been told whenever the opposite is true. We should seek out doctors who aren't in it for that big payout from the insurance companies, but actually are after answers.
Yeah. I mean, on the flip side, I run a free prenatal clinic.
Absolutely.
So I provide care to women who are in a situation where they have low resources and find themselves pregnant, and we do everything for free for them,
which is incredible.
So I give them the same level of care that I would give a paying patient. I don't discriminate. They're seen in the exact same location. They're not seen in a separate wing on a separate day or anything. They're all together, and they are all treated with respect the same way. So that's sort of my way of giving back,
which I love,
and wanting to make sure women have quality care when they are pregnant, even if they don't have any resources. So that's really important to me. But when it comes to this other stuff, the other part of it is sometimes we, in our brain, have money allocated to different things. But our healthcare is like, what is my copay?
Yeah.
What is this? And in your brain, you're like, this is what I should pay for this.
Yes.
And you do pay a lot of money for insurance. I get it. Like if you're paying all this money for insurance every month.
Right. You want to use it.
You're like, well, I can't like spend more on top of that. And I understand that. But it's also, the system is a problem.
Yes.
The system that says you're going to pay us $1,500 a month. And we may not even cover when you want stuff done.
And sometimes you have to send something back for review, and they're like, oh, we actually do cover that. We forgot. We made a mistake. And, and I'm thinking, what about all these people who have 4 kids and can't necessarily call the insurance company for every bill that they get and have them reinvestigate it? There's just, we could do a whole episode on that.
On the physician side, I might never get paid for a visit that I did with someone because the insurance is not paying that claim for whatever reason. Wow. So you have to have a dedicated billing person that's chasing claims all day. And I just want to be paid for my work.
Of course, of course.
I don't want to be justifying what I'm doing to an insurance company who is not even a medical person.
Right.
All they're trying to do is save money.
Yeah.
And your insurance is dictating to you what they will and will not do.
What they think is appropriate for your condition that they have no knowledge
Meanwhile,
about.
They're not a medical person.
Right.
So how that is allowed to happen, I really don't understand, because really that decision making should be between the doctor and the patient.
Absolutely.
And not a third party who has a financial incentive to save money for themselves.
To say no. Yes, exactly. Yeah. Exactly.
It's really unfair, and I think people are realizing, especially since COVID, are realizing a lot of these systems are really not fair. They are being very dictatorial with our healthcare. They're being very controlling. We won't cover this, we won't cover that, And it's like, well, we spend a good portion of our day doing prior authorizations for prescriptions, which we're fine to do. I mean, that's just part of it, right?
Of course.
But think about that from the other side of it. They're saying, well, we don't think this patient should have this drug. Really, what are you basing that on?
Yeah.
Oh, that's not in our preferred tier.
Yeah.
So you decided that these drugs are the best for your patients, probably because you got a side deal.
I was going to say, I'm sure it has nothing to do with the pharmaceutical companies courting them.
Right. You have a benefits manager who is, it's all backdoor deals.
Exactly.
And the patient is the one that has to sit there, and we have to jump through all these hoops to get their prescription paid if they ever will pay it. Sometimes they deny it. And so I think that there's a lot of issues. I'm not a fan of single payer healthcare or anything. That's even more controlled than what we have. So I just want patients to be educated and informed and get mad at these insurance companies and jump up and down, because sometimes they get mad at us.
At you for not taking insurance.
And I'm like, it's not really us. I'm giving you my medical recommendation. They're not wanting to pay for it. Don't get mad at me.
Right.
Get mad at them.
Exactly. And I think that, I can't pretend to know anything really about insurance or about the medical economy. But I think that if we did live in a world where you just pay for your provider's time, you would think that that would lend itself to better care, to not having these exorbitant medical bills or insurance payments every month. So people would have more money back in their pockets to spend at these things. And
Well, think how
you would
many
think it would make more sense.
Commercials. I mean, you're probably too young to have cable still, but a lot of older people still have cable.
Right.
And if you sit and watch shows in
Yep.
the evening, it is show, drug commercial, drug commercial,
Yes.
drug commercial.
And I read that
show.
America is the only place that does that, because other countries don't. I think
Don't allow it.
It was a tweet, or it was some kind of a post from someone who came to America on a vacation, and they were thinking, why do you advertise for medications? This is really strange. And it's something that I would have never questioned. I thought it was just universal until I read that. And then it really makes you think, why are we being advertised for these things that should only be given to those who need them?
Oh, because it's $1 trillion industry.
Exactly.
And unfortunately, the problem that you have is if you're a patient and you're needing a medication and it's very expensive.
Right.
I mean, you saw an ad on TV, and then you try to actually get prescribed that medication. Well, we can't prescribe it to you. You know, there's a lot of problems. I'm not trying to solve all of those issues, but I am trying to say that I think that the power of the pharmaceutical industry, the power of the insurance industry, the power of corporatized medicine is limiting people, is really trying to put them in a box and say, you will do this, you will say this, you will go here, you will do that. And if that works and that is the solution to your problem, fine.
Of course.
No problem. But, my family and I, we have a cost share. And that cost share, and the reason I got the cost share was because I had a baby 10 years ago, my youngest baby. And I had insurance from the hospital that I delivered in. And there was a midwife I was working with at the time that was also pregnant. She had the cost share. So we both ended up delivering at the same hospital. And me with this insurance, I ended up paying almost $2,000 out of pocket, $1,500 or so. They covered all of hers.
Wow.
And neither of us had a C-section or anything like that. Wow. And I was just like, this does not make sense to me. So I started investigating, some of that. And so that's why I sort of encourage patients, whatever it is, whatever aspect of this health journey that you're on, just say, what makes the most sense for me, for my family?
Of course.
What am I dissatisfied with? What do I want out of my health care? Sometimes it's as simple as your choices in childbirth.
Yes.
Okay. So let's say you are pregnant, you're getting ready to deliver, and you're looking at where you want to have your baby and all of these things. And it could be, well, so-and-so delivered so-and-so's baby, or this is in our network, this doctor's in our network, or this is, it's interesting that I feel like in America, we research buying a car or a house more than we do our health care.
Yeah.
And so, I don't know why we have this disconnect when it comes to that,
I have one follow-up question about insurance, and then I have another question about this.
Yeah.
Do you have any cost-sharing companies that you would recommend for people who are interested? Any names that you can give us? Or
So I use one that is secular. I mean, a lot of these are
religious-based.
And some of them are more strict with their requirements for that. Like one of them requires like a letter from your pastor or whatever.
Right.
But I actually offer this in my office for my employees, and they're all different, and I'm not presuming to, tell them how to believe necessarily. So I sought out one. It's called Sedera Health. That is doesn't ask like religious questions or anything like that. But there's Samaritans, there's Liberty, there's Christian Healthcare Ministries, there's MediPay, MediShare. Sorry, MediPay is different. That's actually insurance. MediShare. So there's a lot of them that have come out, and you can kind of research and find which one might fit you the best. But I have 6 children, and that's the other problem.
Yeah.
Commercial insurance, when you have multiple dependents, is prohibitively expensive. And
Yeah.
so these cost shares enabled us as a larger family to be able to have a very affordable monthly amount,
That's incredible.
but still have
Adequate coverage
coverage.
for your children.
Yeah.
That's fantastic. I think that's very valuable. And it's one of those things that, again, because we live in a society that pushes insurance so heavily, that I think it can easily be brushed aside as, oh, we don't do cost sharing. Those are crazy things. Those are for, people who don't believe in, the homesteaders of the world. And I think sometimes it's not taken as seriously as it should be, because it would take money out of the pockets of the people that don't want you to take it seriously. So it's
Yeah.
great to hear about
That's
your
a
positive
great
experience with
option.
them.
Yeah.
My question about deliveries: what questions should women be asking when it comes to picking an OB, whether it's the very beginning of their pregnancy or choosing their delivery methods? What questions should we be asking?
I think it's really hard for someone who is not kind of connected into that world
Mm-hmm.
to know who to go to.
Right, right.
And so sometimes your, mom groups can be
Mm-hmm.
helpful, or if you have friends who have delivered
Of
recently,
course.
especially friends that are more aligned with your own values.
Right.
If you're like, I'm more natural minded, I don't always want
Of course.
everything. Unfortunately, we used to have two birth centers in town,
Mm-hmm.
and that was a really nice option for low risk women.
Mm-hmm.
Unfortunately, both of them have closed.
Mm.
It's really hard in this world.
Yeah.
Hospitals have lots of money,
Yes.
and independent outfits don't always have that same level
Of
of
course.
financial backing.
Mm-hmm.
So I think that's why there's not more birth centers than there is.
Mm-hmm.
Home birth is an option for some women.
Mm-hmm.
For other women, they don't feel comfortable with that,
Mm-hmm.
or at least not for their first baby,
Right.
or their husband's not comfortable with it,
Right.
or.
Right.
So it is important to have birth options, but I will say that I have had women travel for the birth that they want.
Yeah.
In fact, I just had a patient who had twins, and she actually doesn't live in Missouri. She lives in Arkansas. And her first baby was head down, and her second baby was breech.
Mm.
And she wanted to be able to deliver both of them vaginally.
Mm-hmm.
But the vast majority of doctors are not doing that anymore,
Right.
and they're recommending a C-section for that.
Mm-hmm.
She ended up driving to St. Louis, relocating at the end of her pregnancy to get the doctor that would agree to deliver her that way.
Wow.
And to her, it was very important,
Of course.
and she had a successful vaginal birth.
Wow.
And I'm not saying everyone has to go to those lengths, but I'm
But
just
do you
saying,
have the option
again,
to?
you have options. You
Yeah.
have options. I have a colleague of mine. His name is Dr. Stuart Fishbein. He actually is out of LA, and he does breech births at
Mm-hmm.
home,
Wow.
which is very, very unusual for a physician.
Yeah.
There are some
Yeah.
midwives that do that, but he's been doing it for 30 years. I mean, he's a little bit older than me. He's been doing it for 30 years, and he actually teaches conferences where he teaches doctors and midwives how to
Mm.
deliver breech babies, because it's not even being done in the hospital
Mm-hmm.
anymore. It's like
Yeah.
lost art.
And it
When I was
just,
in
we
training, we did some breech deliveries,
Mm-hmm.
especially of the second twin.
Mm.
But the options are very limited.
Oh yeah.
Now, if it's your first baby and nothing is unusual about the pregnancy, and you're not having any problems, and you're young and healthy, and you're like, I can pretty much go to anybody that I want to.
Right.
I just want to make sure that they're compatible with,
Mm-hmm.
listening to me, letting me ask questions,
course.
things like that. That's all very important. But then some people have had not great experiences.
Yeah.
Some people have had traumatic experiences.
Absolutely.
And some of it could be because something unexpected happened in the pregnancy, and they were not expecting to have an emergency C-section,
Mm-hmm.
or they had a stillbirth,
Mm-hmm.
or
Yeah.
something other traumatic happened with them. And this is not like me blaming all the doctors or anything. It's just me saying that you have to be engaged in your healthcare.
Absolutely.
You have to be actively engaged in your healthcare.
Advocating for yourself.
Yes. And if you're in the hospital and your spouse is there, like, your spouse needs to understand how to advocate for you
Mm-hmm.
if you find yourself in a situation.
Right.
I think that it's not because I'm adversarial against the medical system. I recognize its place.
Mm-hmm.
I think it needs to be there. I've had 2 C-sections. I understand sometimes you need
Yeah.
that. I'm all for life-saving care.
Right. Of course.
I'm all for modern medicine when
Mm-hmm.
it works. It's great, and
Right.
I'm happy to utilize it. But there's also a lot of problems in the
Yeah.
birth world.
Mm-hmm.
And if everyone's getting induced
Mm-hmm.
and everyone's getting C-sections,
Mm-hmm.
it's really shaping
Right.
the maternity world.
Absolutely. And now that you know
So,
mention that, I think that the majority of friends of mine that I have had babies have been induced, and it makes you wonder too, why is this happening so frequently? And I think that not only are we misled on the conception end of pregnancy by media and movies, someone finds out because they're throwing up months into their pregnancy that they're pregnant, and it's so accidental and it just happens. And I think that that's the fallacy that I was hoping was true, and obviously I found out that it's a little bit more complicated and nuanced than that. But then when it comes to labor and delivery, then we see all these women on TV and movies, their water breaks and it's so sudden, and then they're rushed into the hospital and then their baby comes out and everything is fine. So in real life, if you stop to think, and I don't know, I can't speak for all the women that listen, but at least in my circle, there are so many different times that, if I don't go into labor by this day, then I have my scheduled induction, and they go in, they call the hospital and they say, "Do you have a bed for me?" And then if they have a bed, they go into the hospital and they get induced, and then they wait. So it does make you wonder, like, what is this? What is this new process? Why is this being pushed so heavily?
well, one reason is that there was a study that came out that was indicating if you induce everyone at 39 weeks, you reduce the stillbirth rate.
Mm-hmm.
And that study actually didn't even really show that, but that's a whole nother story. Um, but it's one of those things that gets ingrained in people's heads.
Yeah.
And so, of course, nobody wants a stillbirth,
Of course, yeah.
most especially the mother.
Mm-hmm.
But it's also devastating for the doctors. I mean, it's supposed to be a joyful occasion.
Right, right.
Obviously, that is a heartbreaking situation.
Mm-hmm.
So you might think, well, we want to avoid that at all costs.
Mm-hmm.
Well, if the cost is by inducing everyone, then you get 30 to 40% of those women having C-sections because
Mm-hmm.
their body wasn't ready
Right.
to go into labor. And then that affects every baby that they have after that.
Yeah.
I mean, you have to look at the long-term effect.
Mm-hmm.
I think that induction can be done in a situation that is a mutually agreed upon situation with the patient
Right.
and the doctor, especially if the woman's cervix is favorable to that.
Mm-hmm.
She's already dilated.
Mm-hmm.
But when you just kind of have this hard and fast rule that everyone gets induced at 39 weeks, there's going to be a percentage of those women that were not ready to
Yeah.
give birth.
Yeah.
And
As this is the same with every one size fits all approach, you would think.
yeah, and if you don't think outside the box, or if you don't, I think what's missing in medicine is a lack of critical thinking.
Mm-hmm.
I think a lot of doctors have just been kind of programmed. This is the way we do it. This is the way we do it,
Mm-hmm.
and their hospitals are sort of making them be that way in a
Yeah.
lot of
Yeah.
cases. They're not to the point of saying the hospital's not saying every patient has to be induced at 39
Right.
weeks. That's not what I mean. But, they don't like women to go past a certain time.
Right.
And all of these factors. So, having worked in a hospital and in a birth center, I kind of have a different perspective.
Of course.
Having had medicated births and unmedicated births has affected me. Having had vaginal births and C-sections has affected me.
Right.
So I've been on both sides of the table, so to speak.
Yeah.
I had my first baby in residency, my third year of residency, which is the absolute worst time to have a
I was
baby,
gonna
by
say,
the
I'm
way.
sure that was a low stress year for you.
It was really not a good time, but
Uh-huh.
of course I wouldn't trade him for the world. He's
Right,
23
right.
years old
Oh.
right now. But I mean, that situation, he ended up being a C-section.
Yeah.
And I was induced, and,
Mm-hmm.
and I thought my body failed me. And one of my mentors, who actually happened to be a maternal fetal medicine doctor,
Right.
who had 2 home births, if that gives you any idea about her personality. But she said to me, "Do you think it had anything to do with your induction?"
Yeah.
And I literally never thought of it until she said that. And I was like, oh my gosh, was that the problem?
Wow.
And it's like the wheels started turning, and I'm like, well, maybe I shouldn't have been induced. And, and then I
Yeah.
started questioning.
Yeah.
And I think it just kind of set me on a path of being, why?
Yeah.
Why do we do this?
Yeah.
Why do we need to do
Healthy
this?
skepticism. You know, you
I
have to
think
ask
it's
questions.
important, that critical thinking, and that, and there are some very good doctors here in Springfield. I mean, there are some doctors that I highly, highly respect. I think are excellent. They do a great job with their patients.
Right.
They're very personable. There's just been some stellar physicians here.
Yeah.
So I don't want to make it sound like, the hospital's a horrible place. I mean, it's not.
Yeah.
It's just, I think that if you, the person, the woman who's giving birth, is not educated and supported, you don't know what's going on.
Right.
You're not really engaged in this care. You're just kind of going by what everybody's telling you.
Yeah.
Because you're like, I'm not
based
a doctor.
on their experiences, based on
I'm just a patient.
Yeah.
I'm just a patient.
But I think what you said earlier that you probably didn't realize has so much weight. Whenever you said you are hiring them to care for you, so we always think that I'm the patient. I don't want to be a nuisance. I don't ask any questions, and even with myself, I sometimes feel bad sending too many portal messages, or I feel too bad, calling to ask a follow-up question because I forgot to ask it before, because you don't want to rock the boat, and you don't want to be stupid. You don't want to ask these questions where the doctor's like, no, that's not the case. And I haven't even had an experience that's been so poor that it should have given me that skepticism or that trauma. But many women have, many individuals have with doctors where you feel as though you can't ask questions because you don't want to waste their time. And just the simple realization that you're hiring those doctors, your medical team, to care for you, that also means you're hiring them to answer your questions. You're hiring them to give you peace of mind and information and to let you understand what the care is that you're being given. You shouldn't just unquestioningly take it and say, oh, okay, this is what we're doing now. You should ask questions until you feel comfortable.
There's a communication problem. So my husband has a completely different practice than me. He works in the ICU, but he's also a pulmonary doctor. So he's a lung specialist.
Yeah.
And time after time, he will have patients say, you're the first doctor who's actually talked to me.
Wow.
I've been in this hospital for 6 days, and you're the first doctor to come in and talk to me one-on-one.
Yeah.
Either the doctor's talking to the nurse, the doctor's giving orders.
Yep.
It's not an interaction with the patient.
Yeah.
And
it's as though you're just data on a page.
Yeah, like you're just a body lying there.
Yeah. You might as well be a cadaver that they're just testing on. It's not like a conversation that they're wanting to know your side of things.
And again, I'm sure they're all busy, right? But my husband's busy too.
Yeah.
But he is number one, a teacher and a communicator. So he wants the patient to know why they're there and what's going on with them. So he's always like talking to them and explaining things. Right. And he always gets people saying, thank you for explaining that. I didn't really understand because nobody's talking to me,
Right. Right.
And it's so sad because here they are, all vulnerable, sick in the hospital.
Scared. Everyone's scared in the hospital.
Afraid of dying,
yes.
I'm sure, and they don't even know what's going on with them. So I think, doctors need better communication skills overall. Right. Of course, the system is unfortunately set up to where doctors don't always have time to do that, and, there are people who have issues with my office too when we don't get back to them. And, we have had nothing but communication problems. My website was hacked. Our phones weren't working. Our messages were going somewhere. We couldn't find them. Patients would say, I left a message. We couldn't find it. So, we didn't answer them because we didn't know. All kinds of crazy stuff is going on. But I think that if they're making an effort to help you, like, I don't mind patients asking questions when I know they're just have questions and they're sincere,
Yes. Yeah.
I don't have any problem with that. I feel like they need to be getting their concerns addressed. They need to have their questions answered. I want them to feel like they're being listened to.
Absolutely. Which is so important.
It is so important. I mean, not every person wants to be like labeled that patient, whatever.
Of course not.
But I don't think it's unreasonable to be asking questions about your own medical care. I feel like it's your life.
Yeah.
Your very life. So I don't have a problem with that. I feel like it's really important to do that.
Yeah.
Now, sometimes we'll say, I mean, if you're sending me 2-page email, then you probably need an appointment.
Yeah, let's just come in. Let's not, yeah.
Come on
Absolutely.
in.
Absolutely.
Let's sit down and talk,
Yeah. So keep your replies to
Yeah.
one page is what
Yeah.
you're saying. Okay.
I mean, a few bullet points
Yeah.
is,
No, of course, totally understandable. I think that I have, of course, endless questions, but with respect for your time, I'm going to switch to a rapid fire format, which won't be that rapid fire because nothing is that simple. But I'll give you shorter questions that are more to the point.
Sure.
Versus all the other ones that I have. So when someone goes off of birth control, what is the average amount of time it will take for their body to recover from that?
That is very variable, but I would say, within 3 months of being off birth control, if you're not having a period, that's a problem.
Right.
If your period is really, really bad, I mean, you might need to give it another maybe 3 to 6 month period
Yep.
to kind of see, if it's going to kind of regulate.
Of course.
However, that's not a hard and fast rule. And if somebody's having a severe problem, I always want to see them.
Of course. Yeah. That's a great answer. If there was a situation where someone wants to put their adolescent on a form of birth control as a contraceptive, then would you recommend any one versus the other? Or is there a certain birth control that you would deem as safer long term with lower side effects, things like that?
I think it depends on the person. So I do on occasion prescribe birth control. So I'm not against birth control or anything necessarily out of hand. But if that person was specifically I need this for contraception, I would probably choose a very low dose method. The difficulty with adolescents is they're not always consistent with their behavior.
Yeah.
And they're not always able to do things that are requiring them to stay on top of it.
Like take a pill every night.
So we have tracking methods and things like that, but some of them aren't mature enough to deal with that.
Right.
So you really have to figure out the individual person and what they would really be best doing. Sometimes I'll be like, okay, you need to maybe think about doing condoms or a diaphragm or something that is something that you don't have to take a pill every day, something like that.
Right.
Obviously, when it comes right down to it, if that person is engaging in behavior that could make them pregnant, you really have to have this conversation.
Right, of course.
And I'm actually very honest with my patients because I happen to be pro-life, and I actually say to them, if you got pregnant right now, would you have an abortion? And if they say yes, then I say, then you and I need to have this very specific conversation about how you're going to take responsibility for this situation.
Yeah,
not that there's not two people involved, okay?
Yeah.
But honestly, in 2024, if you're a woman, you're just going to have to take control of this situation.
Of course.
And you're not going to, you can't depend on someone else necessarily. So I sort of say to them, if you're in this place and you're in this point in your life and you would do that if you became unexpectedly pregnant, well, then let's choose something that's going to have the best advantage. But I will always say to them, if you have side effects, if you have mood problems, if this makes your anxiety worse, if you're having some side effect to this, you need to tell me right away.
Yeah.
So my patients are very engaged with me.
I love that.
And that's why I'm not a fan of over-the-counter birth control being dispensed by your pharmacist, who is not a clinician.
Right. Who doesn't follow up with you.
Who might be like, check off these boxes and then here's your pills.
Yeah.
I mean, that is not healthcare. I'm sorry.
Right.
You need to have an engaged relationship with your healthcare provider in order to be safe for you medically.
Absolutely. Moving from contraceptives to conception, what are your baseline tips for women who are entering into that stage where they're ready to start in the next, say, 6 months to a year trying to conceive? Are there things that women should be doing preemptively to prepare their bodies, things they should be aware of, anything that you should stop doing? Obviously, people get pregnant all the time unexpectedly, so sometimes there are no factors working against you, a couple shots of tequila and you're going to make it happen. But what things can we be doing to prepare ourselves for the best outcome?
I'm always a fan of charting your cycles, learning how to chart your cycles, because I feel like that gives women such great information about even the time to try, because there's women that are not even having sex during their fertile window.
Yeah.
So learning how to do that, there's lots of resources out there now. There's lots of tech now that help women to be able to do that. We have the Ava bracelet, we have the
Yeah.
Aura rings,
Aura ring.
we have
Yep.
all kinds of gadgets that are helping women to
Yes.
kind of know. Now, not all of these are accurate. Like
Mm-hmm.
some of them are just based on algorithms
Right.
that are telling you, oh, you should be ovulating, and you're not
Mhm.
actually ovulating because
Mhm.
your period is irregular.
Yep.
So I would say if you're contemplating getting pregnant and your periods are irregular, seek
Mm-hmm.
help right then.
Yeah.
Go see somebody about your irregular periods,
Mm-hmm.
because you don't want to waste 6 months.
Yeah.
And actually, there could be things that you could be doing for that.
Right.
Obviously, I'm not a fan of smoking. If you
Mm-hmm.
or marijuana, I mean, I don't think either one of those things are good.
Mm-hmm.
Alcohol intake, as long as it's,
Moderate.
mild
Mm-hmm.
to
Yeah.
moderate and not, a problem.
Right.
But also that whole thing that we've talked about with the beauty products, with the food
Yeah.
products, start thinking about the things you're putting in your body.
Yeah.
Think of your
Absolutely.
food as building blocks.
Mm-hmm.
Not that, you can't have Andes or Chick-fil-A or
Right.
whatever, but just
Right.
think of it as, I'm really going to start working on us eating healthier at
Yeah.
home.
Yeah.
I'm going to take a really high quality prenatal vitamin,
Absolutely.
and I have those on my Pinterest. So if you want to go
Perfect.
look
I'll
on
make sure to
my
include those.
Pinterest,
Absolutely.
yeah, just stuff like that, and
Right.
start really kind of gearing up for that, even if you're not
Mm-hmm.
actively trying.
Perfect. Is it a safe assumption to say that if you are having irregular periods, there is something that's amiss? So your periods should be regular, if not, whether the severity is very, very mild or it's pointing to a larger problem, your periods should be regular.
If your period is such that you're asking questions about your period, then there might be something
Okay.
going on.
Good to know. I know
So,
everything varies, and you can't make
yeah.
any blanket generalities as a medical professional without seeing someone, but that's
Yeah.
something that I also think.
If you're skipping your periods,
Mm-hmm.
if your periods are super heavy,
Yeah.
super painful,
Mm-hmm.
if you have a lot of PMS symptoms
Mm-hmm.
or hot flashes, night sweats, maybe your sex drive is not
Mm-hmm.
good. And you're
Mm-hmm.
like, why is my sex drive not good when I'm young?
Yeah, absolutely. That's something that's very common. I've seen in friends both pre and postpartum, pre-pregnancy even. So that's an amazing thing to point out as a side effect, and not just, well, that happens. Welcome to marriage, like
Right.
some people tend to do. So again, a wonderful thing to point out. How common are miscarriages?
Well, that is up for debate.
Yeah,
There
that's another
are
thing I was going to
people
say.
that are quoting that 25%,
Mm-hmm.
which I think is actually high.
Mm-hmm.
So I have a good friend who's an OBGYN in Florida, and we talk a lot because we're very kind of similar.
Right.
And she said, my personal practice miscarriage rate is more like 10%.
Mm-hmm.
And I would say mine is sort of in the, 7 to 10%
Wow.
rate.
Yeah.
But that's also because we tell our patients to call us as soon as they are pregnant.
Yeah.
And we monitor them from the beginning. So we're
Mm-hmm.
not telling them, like, we don't want to hear from you until you're
8
8,
weeks.
9, 10
Yeah.
weeks.
Yeah.
Our patients are instructed to call us immediately, and we're like on top of them with lab work and stuff. So my practice is different when it
Mm-hmm.
comes to that. I think 25% is a very high number.
Yeah.
Um, it's hard though, because you do have women that are having chemical pregnancies,
Mm-hmm.
or they are having really early losses and
Mm-hmm.
things like that. So I think it's difficult to say, but I think 25% is a high
Mm-hmm.
number.
Right.
That being said, I feel like there are more problems that we are having because of our hormone issues.
Yeah.
And I do think that's even in young women,
Mm-hmm.
yes, if you're 35 and older, your losses could be chromosomal. That
Mm-hmm.
is true.
Right.
But having had a baby at 42 after 3 miscarriages in a row,
Mm-hmm.
where everyone thought I was crazy for even trying to have
Yeah.
another baby, and everybody just thought I was old,
Mm-hmm.
I ended up having a clotting disorder.
Wow.
And I didn't know I had that because I never had a clot. I just had
Mm-hmm.
miscarriages.
Mm-hmm.
So we see a lot of that going on.
Yeah.
And after finding out all of that, that was, I took progesterone and stuff, but that was not my major issue. It was
Right.
actually this clotting disorder.
Mm-hmm.
Um, and I was able to have a healthy baby at 42.
Yeah. That's
So
incredible.
I think that, the story, the history really, really matters.
Absolutely. I don't think that you will be able to answer this accurately, but when it comes to progesterone, then there's the oral route, there's a suppository, and there's the injection. What are the defining traits that you would use in each case in defining what would work best for that patient?
It's usually based on what I feel like is working for the patient,
Mm-hmm.
what they like. If they take it and they don't feel good and we try something different.
Mm-hmm.
We do use a lot of oral because it's easy. It's
Mm-hmm.
easy to get. It's not expensive.
Mm-hmm.
People don't mind taking pills.
Right.
So I would say that's probably our first line agent.
Mm-hmm.
But I use vaginal suppositories and shots too.
Mm-hmm.
And there are people that I have that are on multiple forms of progesterone because if they are not, they will lose their pregnancy.
Yeah.
And I would say that part of that is probably the biggest mystery to the mainstream world,
Yeah.
which doesn't make sense because it's actually very physiologic. Progesterone is the main
Mm-hmm.
pregnancy hormone.
Yeah.
Pregnancy progestational hormone is where progesterone gets
Wow.
its name.
Wow.
And so it's not just important in the first trimester, it's important for the whole
Of
pregnancy
course, yeah.
because if you don't have adequate progesterone, your uterus will start contracting, your
Mm-hmm.
cervix will start dilating. So we use progesterone often all the way through the pregnancy. That's a very foreign concept to the
Yeah.
mainstream world.
At this point, anything that's foreign to the mainstream world is bring it on.
So I do find that interesting, but we have a protocol that we follow
Right.
for that. So, and I did not make that up. It's actually was established by an OBGYN that we follow for monitoring those pregnancies, and we
Mm-hmm.
go by those levels and what they should be for each gestational week of pregnancy,
Mm-hmm.
not just, oh, you're in the first trimester, oh, you're not, you need that, oh, you don't.
Mm-hmm.
So I always say we don't guess, we test.
I love that. I love that. Well, that's one of the things I was explaining to my listeners about my personal journey is that in my initial rounds of labs, because my primary care doctor is also very proactive in terms of labs being done. So by the time I got just over 6 weeks, I'd already had 3 rounds of labs done, and my HCG went up and my progesterone went down, and I was on the oral progesterone. So that's one thing that I found in common with a lot of my listeners is that low progesterone is something that you would think is an anomaly, but it's incredibly common.
Very
So
common.
especially with someone who I consider myself fairly healthy, I had an entire panel of labs done for an annual physical like I've had done for the past 3 years, and everything from my white blood cells to my lipids to, everything that I don't even know that I should be asking about. And if you looked at all of that, you would say this is a healthy individual, yet my body's not producing progesterone. And I think that that's something that I would have never known had we not already begun our trying to conceive journey. I would have thought, I'm not going to have a problem at all. I'm feeling great. My mental health is great. My blood work is great. So it just goes to show that there are so many issues that don't present at all that you really do have to seek out a physician that will dig for you.
That's right. And the other thing that I would say that I see a lot is that someone's on progesterone,
Mm-hmm.
but those levels are not addressed or
Mm-hmm.
managed. Like you might need higher doses. You
Yeah.
might need a different form. You
Yeah.
might need adjustment in that way.
Mm-hmm.
But they're like, oh, you're on progesterone. You should be fine.
Yeah.
Well, you may not be on enough progesterone.
Yeah.
There's also a common misconception that if your progesterone is dropping, there's something wrong with the baby, and
Mm-hmm.
all you're doing is prolonging that
Yeah.
process.
Yeah.
And I can just stand here and testify to you how many babies we have saved by being aggressive with progesterone therapy
Wow.
early on.
Mhm.
Some of them have even surprised me. Like, I didn't think this progesterone level was even compatible with a viable pregnancy.
Wow.
But we just kind of, addressed it. And
Yeah.
then that patient carried and was able to have a successful baby. So, I mean, I always say, well, why wouldn't we err on the side of doing everything we could before we throw in
Yeah.
the towel?
Yeah.
Does it hurt you to take progesterone longer until we figure out if this is indeed a miscarriage?
Mm-hmm.
No, this is not something that's harmful to you or the baby.
Mm-hmm.
We have more problems with not being aggressive enough.
Yeah.
So my perspective is very different, but that's also from being a hormone specialist,
Yeah.
from having
Of
miscarriages
course.
myself.
And understanding it's not as simple as a sinus infection. Let's try antibiotics, and if it doesn't work, then we'll try something else. this is a life and this is a baby and this is, your journey to becoming a mother. We want to take it as seriously as we can and err on the side of being aggressive, but also on being optimistic and fighting for this life versus just, well, if this doesn't work, we'll try again,
Right. And also, all bleeding is not miscarriage. So some women are bleeding and they're like, oh, I've lost it. There's nothing I can do.
Yeah.
And I'm, or even the doctor's office will say, oh, well, you're miscarrying. It's like, no, I've seen lots of women that were bleeding. The baby was still alive. We were able to kind of get in there. Now, obviously, if things are coming super heavy and you're like, this is definitely a miscarriage. Yeah, I understand that. But what I would say is before you even get to that point, that's why our patients are told to call us when they get a positive test.
Yeah, that's incredible.
We say you can go ahead and tell your husband first. But
but we should be the second call.
Call us after that.
Immediately, yes.
We want to know right away.
Of course.
We don't want you waiting until you start cramping or spotting or, any of that stuff.
Yeah. Well, I've said this a million times. I sound like a broken record, but that's such a breath of fresh air. And it's incredible that you have this passion that's tangible just in the way that you're speaking. It's not just something that you punch a clock and you do your job and you check your list and you go home. And I think that that's something that instills so much confidence in me as a soon-to-be patient. And shouldn't any woman just listening, whether they need your services now or if they never do, I think just knowing that there are physicians out there that are seeking the betterment of women's health, that are looking for innovation and just genuine care. It's not always about medical advancements. It's just about using the information that we have better. So I can't thank you enough for the work that you're doing. My last question, how can we support the free clinic that you run? Do you accept donations? Is there something that people can do if they feel called to support you?
Yes, thank you so much for that.
Of course.
So we have a Patreon. So I'm not sure if you're familiar with that, but it's where you can give a small monthly amount to support whatever the situation is that you're supporting. So if somebody wanted to go to Patreon and look up Dr. Poppy, you can go on there. There's actually a link on my Facebook page.
I'll make sure to include that too with the episode.
At Dr. Poppy. I'm on Instagram at Dr. Poppy BHRT, and that's also on X or Twitter.
Perfect.
My website is drpoppyandco.com.
Perfect.
So there's a lot of info on there. People do drop off donations to the office sometimes too. Sometimes anonymously. For a while we had a little angels that were just dropping little envelopes of money, which is great.
Of course, yes.
But, the other thing that I think it's important to understand is we do payment plans.
Yes.
We have, our patients were like, we would like you to get this amount of blood work, but you can spread it out if you need to spread it out.
Yeah.
Like if you can't afford to do it all at once, you can, do it over time. So we do try to work with people financially too, who do want to come in and get their problems looked at. It's not just for rich people.
Right.
We see a lot of ordinary people who just want
who have bills to pay and still want that closer look. Well, I can't say enough thank you on behalf of me, my listeners, women in the area, everyone that you have benefited, just the work that you're doing and the advocacy that you're doing. Thank you for your time, for your expertise, and thank you in advance for the work that you will be doing for me. And is there anything else that you would like to say before we close out to the listeners, to the women that we have?
Well, I'm grateful for this podcast. I'm glad that you're doing that. You might think this is not having much of an impact, but it really, really is. And being able to talk about these issues, so important. So congratulations on doing that. I think more people should sort of follow their passions and really pursue doing something like that. And I really appreciate the opportunity to talk with you today.
Well, it's been my pleasure. Thank you so much again. I really appreciate you.
Thank you.
Thank you. And thank you guys for listening. We will see you next week. If you're interested in learning more about Dr. Poppy, I will link everything that we mentioned down below. But thank you for tuning in, and we will see you soon. Bye.